Hello, everyone. My name is Colleen Baker, and I am a DNP candidate at Maryville University. And this is a recording of my presentation for my quality improvement project, Improving Pain Reassessment Documentation in a Progressive Care Unit through Audit and Feedback. I'd first like to thank my committee, specifically my chair, Dr. Dell, and my second reader, Dr. Stegman, and also my community partner, Barbara Stegman. Without their mentorship and feedback, I would not have been able to complete this project. So thank you to the three of you. So to begin with background, timely pain reassessment following PRN analgesic administration is a national standard and is an important part of safe, high-quality nursing care. It's tied not only to pain control, but also to patient satisfaction, length of stay, and patient outcomes. Guidelines from the Joint Commission and institutional policies specify a reassessment should occur within 30 minutes for IV or IM analgesia and for 60 minutes or within 60 minutes for PO. However, evidence suggests that pain reassessment documentation remains inconsistent and continues to be a target for quality improvement. On the project unit, leadership noted that nursing staff were often completing reassessments on time, but not consistently documenting them. This made it difficult to track compliance, evaluate care quality, or meet auditing requirements. This project aimed to improve documentation of pain reassessment through an audit and feedback approach designed to support accountability and to promote consistent charting practices. So some of the support. Reassessment is a national standard, like I mentioned, but a real-world challenge to it is documentation. Studies show that while nurses often do reassess pain, follow-up isn't always charted. This affects the ability to evaluate care, close the loop, or meet compliance standards. Wisman and colleagues found that reassessment documentation rates were low in busy environments, and that simply creating awareness of the documentation gaps themselves helped improve compliance. Yang et al. Added that when reassessments aren't documented, it's harder to gauge whether pain management has been effective, which can lead to delays in additional care. It also creates blind spots for providers, auditors, or state surveyors. Mitchell et al. Really captured the reality of clinical practice. They found that nurses are performing reassessments but skipping the charting, often because the workflow doesn't reinforce it or they don't see it as a priority. And this aligns with exactly what was seen on the project unit prior to intervention. The care was happening, but the documentation wasn't. That disconnect became the main target for this intervention. So after identifying the documentation gap, the next step was choosing an approach to address it. And the literature consistently supports audit and feedback as an effective strategy. For this project, feedback meant providing nurses with weekly individualized reports on their pain reassessment documentation, along with public unit level compliance metrics. This meant the unit performance average rate was announced during huddle. The goal was to improve visibility and accountability in a supportive but non-punitive way. Wisman and colleagues applied a similar audit and feedback model in a high-volume emergency department. Their baseline documentation rates were low, and after implementing regular performance updates, compliance improved significantly. Their work closely mirrors this project's approach. Lodger's team in a burn ICU also used individualized data-driven feedback to improve delirium documentation. Although their method wasn't weekly, it did demonstrate that targeted performance feedback can directly improve documentation accuracy. Leadership engagement also plays a significant role. Dodd highlighted that when documentation expectations are clearly communicated and reinforced at the unit level, consistency tends to follow. It's important to note that none of these strategies required major system changes. They're practical, cost-effective, and adaptable to busy environments, just like a progressive care unit. This is why audit and feedback was selected for this project. It's supported by evidence, realistic to implement, and well-suited to this unit's workflow. So the theoretical framework selected for this project was the PDSA cycle. First, in the plan phase, we identified a gap. Reassessments were being done, but not consistently documented on the project unit, which again made it hard to evaluate care quality or to meet auditing requirements. The do phase was the implementation of weekly audit and feedback strategy style intervention, with both individual and unit level reporting. In the study phase, I analyzed documentation trends after the full 6-week intervention was complete, comparing pre and post intervention compliance. And then in the ACT phase, involved disseminating the results, first to unit leadership and now in this academic setting. While we didn't revise the intervention during the project, these findings can inform future adaptations or expansions. The PDSA cycle helps structure the work while staying realistic for a busy progressive care unit. No system changes, just consistent evaluation and visibility. So methods and design. This was a quality improvement project conducted on a neurology and neurosurgery progressive care unit at a large academic hospital in the Midwestern United States. The design was a retrospective pre- and post-chart review. After the intervention had ended, performance was analyzed prior to initiation and after. The intervention itself was a 4-week audit and feedback strategy. Each week, documentation for PRN or as needed pain reassessment was reviewed, and then individual and unit level compliance was calculated, and performance reports were generated. Nurses received their reports privately, while unit performance was shared during huddle. The intervention did not involve any policy or workflow changes. It relied entirely on existing documentation expectations, and it reinforced those using routine performance feedback. My focus was specifically on whether pain reassessments, which were already being performed on the project unit, were consistently documented. I collected and analyzed all data after the intervention ended to avoid influencing results mid-cycle. This setting, the sample was collected with a retrospective chart review, extracted from the EHR or electronic health record of the patients that were admitted to the project unit. The review focused on PRN analgesics administered by IM, IV, or PO routes, with reassessment documentation evaluated based on institutional policy timeframes. All of this to say, a reassessment needed to be documented for an IV or IM medication within 30 minutes or within 60 minutes for an oral medication. The nurse sample included full-time employees or part-time employees, staff nurses of the project unit during the interventional period. Exclusions applied to float staff, orientees, and travelers. So getting to the actual results, in total, 1,188 medication administration events were reviewed, which were pretty evenly split across the pre and post interventional periods. In the pre-interventional period, 573 analgesics were reviewed, administrations were reviewed, and 615 in the post-interventional period. These results found a modest increase from 57.2% documentation compliance in the pre-interventional period to 59.7% in the post, which is about a 2.5% improvement, which was not statistically significant with a p-value of 0.32. However, this upward trend does suggest that the intervention still may hold promise. While the change was small, it points toward potential impact if scaled properly or paired with other efforts. So this project had several limitations that are of note. First, the intervention was conducted on a single unit within one hospital, which limits generalizability. Additionally, while a large number of individual PRN administrations were reviewed, the study included only 4 weeks of data post-intervention, which may have not been enough time to observe any sustained change. Perhaps most importantly, the pre-interventional period may not have reflected a true baseline. A visit from the Joint Commission occurred shortly before before implementation of the intervention, which prompted increased focus on pain management and documentation practice by unit leadership. During the visit, surveyors and leadership emphasized aspects such as appropriate medication ordering and first and second line agents for pain management, but did not specifically address pain reassessment. Although no formal changes to practice were introduced, this heightened attention may have temporarily improved documentation rates, and as a result, the baseline compliance rate was potentially elevated, which could have diminished the apparent impact of the audit and feedback intervention. The project didn't show a statistically significant improvement, but the small increase in compliance and the upward trend suggests that audit and feedback may still hold promise, especially when paired with other supportive strategies. It's an affordable, scalable approach that could be refined and used more broadly. That said, the timing of the implementation matters. Competing priorities like a regulatory visit and the resulting competing priorities from unit leadership could have diluted the impact in this project. Visibility, reinforcement, and integration into unit culture likely hold major influence whether an intervention like this can take hold. Ultimately, while the results were modest, they highlighted both the potential of this strategy and the importance of thoughtful timing and context in quality improvement work. This project reinforced that documentation practices, especially around pain reassessment, don't exist in a vacuum. Even with a targeted intervention, we saw only a modest improvement, which makes sense, given that pain reassessment is influenced by broader systems issues. This includes things like unit culture, workflows, how pain management is ordered, and effects from things like state visits. The intervention, a weekly audit and feedback approach, was simple and low cost. It may not have led to statistically significant gains, but it is scalable and sustainable. and it generated awareness and conversation regarding a needed practice change amongst nursing staff. That alone is valuable. Rather than abandoning this strategy, future projects should consider strengthening it with real-time feedback, integration into existing workflow, and offering opportunities for staff input. Ultimately, this work highlights that improving documentation compliance isn't just about educating staff. It's also about creating the conditions where nurses are actually supported in meeting those expectations. Embedding pain reassessment reminders into the EHR or reducing documentation workloads through streamlined charting tools could bridge the gap between intention and action. Sustainable improvement will come from making the right action an easy one. So in conclusion, pain reassessment continues to be an opportunity for improvement, especially in high acuity environments like neurology and neurosurgery. This project demonstrated that audit and feedback can be implemented with minimal resources and can be generally well received by staff. While the project did not see a statistically significant change in compliance, it doesn't mean the intervention itself wasn't valuable. As we've discussed, external factors like regulatory activity, staffing ratios, and documentation burdens play a large role and are difficult to control or account for in real time. Still, the project brought attention to a key clinical expectation and created a space for conversations around best practices. Moving forward, embedding reminders or streamlining workflows within the EHR could alleviate workload and better support nurses in meeting pain reassessment standards. Personally, this project and the DNP journey as a whole has challenged me to think beyond individual interventions and has made me consider how systems drive sustainable change in healthcare. It's given me the perspective to approach challenges not just as a clinician, but as a systems thinker, and it's shaped the kind of nurse leader that I'd want to be, one that listens, collaborates, and advocates for meaningful change. Thank you to everyone listening. I'm grateful for the opportunity to share my work, and I welcome any questions or feedback.